Well, now we're ready for our next speaker. We have here on the schedule Dr. Nermeen Hassan. She's an assistant lecturer at endodontics at Cairo University, and her topic would be big shapes do not create better outcomes. Very interesting. And finding the balance between too much and not enough. Let's go and look into that. Okay. Please do welcome Dr. Nermeen with us, please.
Good evening, everyone, and thank you for the warm welcome. To start with, I want to apologize on the behalf of Dr. Riham Hassan. It saddens me a lot that she's not sharing this lecture with me due to her recent car accident, and I'm very sad that she's not even here witnessing this lecture with me because she has been with me every step of the way. So to start with our lecture, as it was introduced now, big shapes do not create better outcomes, finding the balance between too much and too enough. My name is Nermeen Hassan, and I'm an assistant lecturer in Cairo University. The topic about this lecture actually started as a debate 8 years ago in our dental practice when me and Riham, I started the residency in Cairo University, and we started to debate all the time because I used to really love the big shapes and the wide lines, the white lines in the x-rays, and I used to love the great tapers in the files, and she used to say, no, you're not conservative enough, you're damaging too much of the tooth, you're removing too much of the dentin, and you're sacrificing a lot. And then later on, I started the last year the PhD program, and as we all know, Professor Dr. Salsabil, the founder of endodontics in Cairo University, she's the head of the program, and she spiked the topic of minimally invasive endodontics as one of the topics taught over there. I started researching the topic of minimally invasive endodontics, and I found one repeated question, and I call it the inevitable question that we all ask ourselves all the time, which is, why do endo-treated teeth break? And actually, this was a focus of a lot of research throughout the years. Actually, if we went back 3 decades ago, they specified or they hypothesized that the endo-treated teeth break due to 2 reasons. The first one, which is the reduction of tooth structure or the reduction of the tooth stiffness. But actually, they found when they compared the normal or traditional root canal, root access cavity versus an MOD cavity, they found that the reduction of the tooth stiffness was 63% compared to only 5%. So this hypothesis was kind of disregarded. The second hypothesis, and they concluded that the risk of fracture increased with increased removal of dentin and tooth structure. The second topic, or the second hypothesis, was that the endodontic treatment caused dehydration and desiccation of the dentin. But then again, they studied this in an article called Are Endodontically Treated Teeth Brittle? And this was published in 1992. And they found that there is no difference in the micro-hardness of root canal treated teeth versus the vital teeth. So we ask ourselves now, what is the problem? Or why do endo-treated teeth break? Throughout the years, a lot of research has been published in this topic, and one of the main factors that have been hypothesized is age. As we all know, as the person ages, the mineral content in the dentin increase versus decrease in the collagen content, which act like a cushion against the stresses. And with the age or with aging, the microstructure of dentin changes, leading to a reduction in the ultimate tensile strength of the tooth, leading it to be more susceptible to fracture. The other factor that attribute to fracture of the tooth is the intracanal medicaments and the irrigating solutions that we use. I know that we cannot not use irrigating solutions, but we do need to know that it does affect the dentin in some way or another. And when they studied the effect of sodium hypochlorite in this macro photograph, you will see that after immersion in water versus immersion in sodium hypochlorite, spontaneous cracking occurred in the dentin, which led to the conclusion that the sodium hypochlorite concentration will reduce the elastic strength and flexural strength of the tooth. Another review published on the effect of sodium hypochlorite, and as you can see, a lot of studies with different concentrations, different mode of application, and different time of application, and they deducted that regardless the time and regardless the concentration, application of sodium hypochlorite will lead to the dentin to become brittle. And then the intracanal medicaments, as we all know, we use the calcium hydroxide all the time in our clinics. And in this study, it was comparing the effect of calcium hydroxide on dentin versus bioactive glass. And as you can see here, the starting point is at 203 megapascal. And after 1 day of application of calcium hydroxide, it decreased to 175. And then after 10 days, it decreased again, and it plateaued for 30 days. And as we all know, we need to applicate the calcium hydroxide for at least 1 to 2 weeks. So after discussing the several factors of why do endo-treated teeth break, we need to find the balance between the goals of endodontic treatment, which is the ultimate goal of preventing infection and preventing reinfection, and long-term retention of the tooth and improving the longevity of the tooth. And here, the concept of minimally invasive endodontics emerged around a decade ago. This concept revolves around maximum conservation of tooth structure, either from the coronal, the cervical, the radicular tooth structure during all the procedures of the endodontic treatment. So we start with minimally invasive access cavity, and then radicular apical preparation, and finally the flaring part, which is connecting the coronal to the apical preparation. In this part, I will discuss how to reach a minimally invasive concept, and I would discuss the tools that will help you reach this concept. So for the coronal access preparation, we start by shifting from being an apex-centric, which means that we only focus on reaching the apex of the tooth, and we stop or shift from carving a superhighway straight line down to the apex, and we stop sacrificing massive amounts of tooth structure in order to preserve more tooth structure. As we all know that the access cavity is the most important phase during the endodontic treatment. And if we want to start by first talking about the traditional access cavity, they are now described as geometrically pre-designed plan shapes that do not change according to the case. And just a quick hint that will later on matter with the presentation, we used to have a straight line access towards the root canal orifice, and then we have the convenience form, which is removing this part of dentin, or this triangle of dentin, to be able to reach the primary curvature or the apex in case of straight line canals, and finally the extension for prevention. But what about the conservative access cavity? They are described as planned cases or planned access cavity tailored to each case. So we have different access cavity designs. We have the conservative access cavity design. We have the caries-driven access cavity. We have the ninja access, and we have the truss access. And either authors have classified them into traditional, conservative, and ultra-conservative access cavities. So the concept of minimally invasive endodontics revolve around saving this area. This area is called the pericervical dentin, which is the 4 millimeter below and above the cemento-enamel junction. And it has been proven that it allows for better distribution of functional stresses in the teeth, and the more dentin that is kept, the longer the tooth is kept. One of the other concepts, and I know some of my students will kill me now if they're in the audience, because I used to tell them, remove the roof. If you find any catch, you have to remove it. But now the concept has been changing, and actually preserving the roof or part of the roof, which is called the soffit, will allow for better functional distribution, and actually it increased the resistance of the tooth to bending. And if we want to talk about the anterior teeth, we start to here to preserve the pericingulum dentine, which again helps in better distribution of functional stresses. So the hierarchy of needs have been shifting towards preserving the pericingulum dentine and the pericervical dentin, which needs to maintain the optimal strength and the fracture resistance. So now the concept is sacrifice versus compromise. Give you a little bit of a hint about every and each access cavity. First of all, the dearest to my heart, which is I'm starting to apply nowadays, which is the caries-driven access cavity. And from this, you start to enlarge through the carious lesion that already is happening in the case, but without removing all the pulpal roof, and without removing extra pericervical dentin as much as possible. While for the conservative access cavity, and this case is not popular as much in our Egyptian culture, because most of our patients come in when already the tooth is destroyed or carious, but in some cases the tooth is sound, and for periodontal reasons you do have to perform an endodontic treatment. And now we shifted from saying that the access cavity should be in the mesial half of the tooth to the mesial quarter of the tooth, and we start to shift away from the cusps to prevent their destruction and to prevent or decrease their deformation. While for the anterior teeth, we shift from having the palatal, the access cavity in the middle part of the palatal surface into a more incisal manner. And here is an X-ray showing you a straight line from the access cavity towards the root canal, and all the pericervical dentin or the pericingulum dentin has been preserved. And to be honest, I'm not as experienced enough to be performing such ultra-conservative access cavity, but I will give you a hint about them. The Ninja access cavity, and it is drilling a small hole inside the middle of the tooth, and it is equally balanced buccally and lingually, and from this small hole, the clinician can reach all canal orifices one at a time. And finally, the truss access cavity, which is an orifice-directed access cavity where the clinician drills holes directly above the orifices of each canal, and then cleaning them one at a time and filling it much, much easier than the traditional access cavity. And this is the case in the lower. So what are the tools that we can use or utilize to achieve such a conservative access cavity? First of all, the human eye, which is God's gift to us, but the resolution of a human eye is 0.2 millimeter, while with magnification you can reach up to 0.006 millimeter. And because we as an endodontist work in a very small space, we do need magnification to be able to visualize hidden anatomies and hidden canals much better. And as you can see here, with different magnification, improvements in the visibility does occur. one of the very important tricks that I've been using throughout the years, which is the water bending effects. And as we all see on social media videos, they place a water drop over the lens of the camera phone, and it increases or it improves into a macro lens. And in this photo, you will see the water bending effect magnifying the axis cavity to be more clear. And in this one, you will see that without the water and with the water, there is a difference. The tools that can be used nowadays, because the traditional tools were not or were large enough, using a conical burr or a burr similar to the fissurotomy burr, you can preserve the roof and the pericervical dentin and also expose the orifice without sacrificing too much dentin. And because endodontics is the only dental discipline where we do it in the dark, so we have to know before we go, utilizing the functions of CBCT are very important when facing a difficult case. And hopefully this program will be present or launched in the Middle East, which is SciCat Endo, and it's more dedicated towards the endodontic treatment. And with this application, you can use or you can perform a stent that will help you to be guided towards your canals with the minimal conservation of the tooth structure. As for the instrumentation, throughout the years, there have been an evolving look. Starting from the 30s, we used to see very white, narrow lines because we had stainless steel and carbon steel files. And then with the improvement and with the introduction of night-eye greater taper files, we started to see broader white lines. But then again, recently, the less tapered naked titanium files have been available in the market, preserving dentin as much as possible and still achieving good results. So why do we need to preserve the root dentin? Because with increased removal, the stresses shifts apically and increased in a buccolingual direction, which leads to more susceptibility to fracture and vertical root fractures. And because we don't need to remove that much dentin, according to this study by Bertucci, we see that the buccal canals have an apical diameter of approximately a 20K file, and for the palatal canal, it's approximate to a 30K file. So according to this picture by Dr. Martin Troop, a file of 35 tip size with 4% taper is adequate enough to remove enough dentin to decrease the bacteria and eliminate the biofilm and still preserve as much as possible from the root canal dentin. And according to this review, because apical shaping and canal tapers were not significant enough to affect the outcome, and it did not differ regarding the clinical outcome of each case. So regarding the tapers, using an 0.4 taper had the highest stress, highest fracture resistance, while the 0.8 taper had the lowest, and 4 and 6% didn't differ dramatically. But with using a 6% taper, it improved the irrigation as much. So when we talk about irrigation in any endodontic clinic, there should be some sort or some way of activation. It can be manual agitation using the files or using the master cone even, and it can be something like, and this is a video showing you that even through a truss axis, the irrigation from this side will be able to arrive at this side even without any activation. But using activation like ultrasonics has been very beneficial, especially in cleaning the tissues under the soffit. And also we can use one of the instruments that have been available now, like the XP Endo, AF Max, and True Shape, which can help in agitation and 3D cleaning and shaping. And finally, the flaring part. And historically, it has been advocated that we need to remove and flare the canal as much as possible to be able to fit the pluggers adequately, to be able to obtain good obturation. But now, with the improvements in the bonded obturation systems and with the rise of bioceramics, we can use a matched gutta-percha cone with bioceramic sealer or bonded sealer, and we do not have to sacrifice that much dentin. So to conclude the second part of this presentation, only remove enough dentin for successful disinfection and not for obturation. After discussing the concepts and why do endo teeth break, we need to think about a little bit of a research. We cannot adopt any new concept without research regarding is it successful or is it just a facade that's going to be ending in a year or two. And in the literature part, I categorized them into categories, which is fracture resistance of the tooth, instrument efficacy, the errors, and the preparation time. For the instrument efficacy, for the fracture resistance, when comparing both access cavity designs, as we will see here in this picture, this is the conventional or the traditional access cavity, and this is the conservative access cavity, and this is the ultra-conservative access cavity. When superimposing the three cavities over each other, you will be able to see the amount of dentin that is saved with each access cavity design. And it was shown that preserving more tooth structure will reduce the stress concentration, especially in the cervical area, decreasing the susceptibility to fracture. And also another study comparing the fracture strength, and the very interesting thing about this study that even though using a conservative type of access cavity, it did improve the fracture resistance, but for the percentage of unrestorable fractures, all three categories, either the traditional, the conservative, or the ultra-conservative, had similar percentages of unrestorable fractures compared to no access cavity at all, which means that no matter how much dentin you remove, it will break unrestorably at some point. And for another article, you can find that having a conservative access cavity will help in removing less than twice the dentin when using a traditional access cavity. And they concluded that having a conservative access cavity is a double-edged sword. We do improve and we do preserve that much dentin, but on the expense of increasing the curvature of our endodontic instruments. And for the instrument efficacy, if you want to see the percentage of untouched walls when comparing the conservative versus the traditional, 57% was not touched using the conservative access cavity, and 33% or 36% of the traditional access cavity were touched. But when trying to evaluate the amount of dentin volume removed, almost less than half was removed by the conservative access cavity versus 60%, which is more than half of the dentin was removed during the traditional access cavity. And this is another paper showing that having a low taper will preserve greatly a lot of dentin. And if we want to see the instrument separation in a file, let's say the Pro Taper file, and don't get me wrong, it's the first file that I held in my hands when I was in the undergrad year, but things have changed. The percentage of separation of Pro Taper files are 47% in mandibular molars, 61% in mesiobuccal canals and maxillary molars, 90% in the apical third of the root canal, and 54% in the severely curved canal. And this actually helped the manufacturer of Pro Taper to recently introduce the TrueNatomy kit, which adopts the concept of minimally invasive endodontics, and they no longer have the progressive taper that we are taught in every undergrad school, and they're shifting towards a minimally invasive concept. And the presence of coronal interferences affected the number of pecking motions that we can use to reach the full working length, with a mean of 8, and with a mean of 13 times to reach the full working length, which means that we need to peck the canal more times to reach the full working length when having a contracted access cavity. And for the detection of secondary MB2 or MB2 canals, using the conservative access cavity will still be able to detect the MB2 versus having an ultra-conservative, which will lead to decrease in the detection of MB2 canals. And finally, when we want to see the time, it took over 1 hour and a half to finish a molar compared to only 30 minutes in finishing the molar with the traditional access cavity, and this can lead to fatigue of the clinician and the patient. So finally, I'm leaving you with tough decisions ahead. I did not give you things on a gold platter that you need to adopt the minimally invasive concept and do not shift away from the traditional. No, you need to invest more in your tools, and you need to read more about the new concepts emerging in the modern endodontic field, and you need to be a long life student. The more you earn, the more self-confidence you will have, and you need to put your knowledge into practice, because otherwise it's of no value. And remember, minimal intervention is a philosophy. It's not a technique. I adopted it in having a less taper instrument, but I didn't adopt it as much in the access cavity. Maybe later on I will improve my experience, and you can adopt this philosophy in every restorative procedure that you have. And I was lucky enough to meet Dr. Yushi yesterday, and even though he showed us hundreds of cases of broken file removal, in each case he said, I try to be as minimally invasive as possible and remove as much dentin as possible. I leave you with this. The pulp is a big issue about little tissue. So you need to relax a little bit. It's just endo. Thank you so much for having me. If you please scan this QR code, you will find all the literature that I have been supplied to during the lecture, and you will find all the papers that you need to strengthen your knowledge about minimally invasive endodontics. If you have any question, I'm happy to take them. Thank you.
Okay. Well, thank you very much, Dr. for your presentation. We have a minute for a question, if anyone has. Okay, I don't have a question, but I have a statement. Thank you very much for the presentation to begin with. But just a little statement when you discussed how the Pro Taper was introduced and the problems they had. I'm not here to speak for Dentsply, but the regressive taper, the true anatomy of Peters, when he came up with the file, it doesn't mean that they're stopping the progressive concept.
No, they're not stopping the progressive concept, and it can apply maybe in anterior teeth and in premolars where the canal anatomy allows for a progressive taper, but I mean adopting a 6% taper in a canal that is already very tiny and very narrow, that's removing a lot of dentin. And that's why if you look up their page in the true anatomy page, you will find that they focus on having a conservative approach.
Fine. Well, okay. Thank you very much.
You're welcome.
Just to follow up on that statement, the point is that we have 3 different systems in Dentsply. We have the single file technique, and we have the progressive taper and the regressive taper. Each one is going in different directions. So if any misunderstanding on this, as I did, is wrong. Maybe I misunderstood it, but it's a totally different concept. Thank you very much.
Thank
and on
you.
behalf of the Egyptian Dental Syndicate, I'd like to provide you with a certificate of appreciation.
Thank you so much for having me.
And look forward to have you again there.
Okay, thank you so much.
Thank you very much.
So much.
Appreciate it.